I think we'll go ahead and get started. I'm Kim Bailey, Program and Education Specialist with Alzheimer's Orange County. I'm delighted to welcome you back to our second session of training for professionals who are serving individuals with intellectual and developmental disabilities. And just as a reminder, last time, we talked a little bit about the past to begin with and how historical treatment of individuals who are living with intellectual and developmental disabilities, that historical treatment of them led to poor outcomes in later life. And so now better understanding and the increased network of programs that all of you are involved in and provide have led to a much higher quality of life for individuals living with IDD. And we also talked about the fact that lifespans have increased dramatically for people living with IDD over the past decades, and that mirrors the general population. And so people that are living particularly with Down syndrome, because remember, we're focusing on Down syndrome because they are the folks that are at the highest risk for Alzheimer's disease, are now living well into their 60s. However, their risk for Alzheimer's dramatically increases as they age. And then we also talked in the second half about Alzheimer's disease, and I'll do that review in just a second. Well, let's go ahead and plunge in then. And as a reminder, the curriculum that we're using today comes from NTG, the National Task Group on Intellectual Disabilities and Dementia Practices. And we are so pleased to be providing this opportunity for you free of charge as a result of a grant provided through the Administration for Community Living that was awarded to OMID, Multicultural Institute for Development, and we are collaborating with them, Alzheimer's Orange County. So, I already covered a little bit about the first half of what we did last time. And then after we talked about that little history lesson, we went into some specifics about Alzheimer's disease. And we talked about the terminology we use. We talked about dementia being a broad term that describes any progressive degenerative brain impairment that affects memory, in particular short-term memory, the thinking process, judgment. We got into behavior a little bit, and we're going to focus on that today, as well as communication. We talked about Alzheimer's being the most common type of dementia, and it is in fact the major illness that is most likely to affect the IDD population. So we looked at, the prevalence rate, and in fact, individuals who live with IDD are at about the same level of risk for Alzheimer's as the general population, with the exception of those with Down syndrome, and they are at a very high risk of developing AD in later life. And remember, we talked about that because it's due to that extra chromosome, which is the one that's responsible for the extra production of the amyloid protein, which we talked about being the culprit in Alzheimer's disease. And remember, we said that 100% of individuals living with Down syndrome it's been found that they have plaques, the amyloid plaques and tangles in their brains upon autopsy, although not all of them go on to develop the disease. And we ended by talking about some of the early symptoms of AD in the Down syndrome population, that new onset of seizure activity, mood changes, changes in gait and coordination, apathy, lack of interest in their usual work and social activities, agitation, etc. So today we're going to start by talking about communication. I want to cover 4 key communication strategies that can help you handle some difficult communication challenges. We'll cover how our own emotions and our body language influence how our residents and our clients react, sort of a domino effect. And then I'll cover some tips on communicating with individuals who are living with IDD and who have developed dementia. And then in our next module, we'll talk about how laying a great foundation for communicating and connecting is going to help us handle some of the typical behavioral challenges we see. Okay. So, when we look at the whole issue of our clients and the challenges that they are already dealing with, and then we add the extra layer of dementia, it requires a shift in our thinking. More than ever, we need to understand that our clients do not see the world in the same way that we do. More than ever, what we see as normal can be very confusing and even threatening. More than ever, we must enter their reality as they cannot conform to ours. More than ever, we need to be even more patient, supportive, and understanding. And more than ever, we have to change because they cannot. And I keep saying more than ever because these are sort of the basic beliefs that you already know. You're already doing this. It's just that you have to ramp it up even more now that dementia is entering the picture. So I'm not telling you anything you don't already know because you have this history of working with these clients. And so this is not new information. It's just that you're going to be called upon to be even more flexible, even more understanding, and even more patient than you have in the past. And I know you can do it. So, just sort of thinking about communication in general as it pertains to all of us, it's just so incredibly important in terms of how we communicate the things we need, our wishes, how we express our feelings. And all of this speaks to how we maintain our quality of life and our sense of who we are as individuals. And it's so much more than the words that we use. It it's also our nonverbal expressions. It's the emotions on our face. It's touch. It's gestures. And this becomes so key as dementia progresses and language skills are lost. And I emphasize this because if you think back to our discussion last week, when I talked about the progression of dementia in individuals with Down syndrome, it moves pretty quickly relative to how it moves in the general population. And if you recall, I said in the general population, if you know someone with Alzheimer's disease, it can go on for many, many years, but not so in the Down syndrome population. It's going to probably last about 5 years, maybe more, maybe less. It varies from individual to individual, but they're going to lose their language, you know, pretty fairly quickly. And of course, it depends on their baseline functioning before they get the disease. So, use of nonverbal communication is going to be very key. Body language is also key because people with dementia are very good at reading our body language and responding to that. So, again, being calm and patient, open and self-confident in our approach is going to make a big difference. We don't want to stand over someone, their perception changes, their vision changes. We want to be at eye level with people. We don't want to approach people from behind because that can provoke a startle response, and it could even endanger us because they might take a swing at us. So, when we do approach people, we want to smile, we want to be open, and we want to identify ourselves, even if they've always known our name. We can't assume they're going to remember that. So when I'm approaching my clients, I always just say, "Hey, it's Kim. I'm so happy to see you. Let's go have a snack," or let's fill in the blank, whatever the task or activity is going to be. If that client is comfortable and it's appropriate to have some sort of body contact, touching their arm, again, while you're facing them and making eye contact with them, or holding their hand, can be reassuring. Reassurance is just the name of the game, because once people have dementia, they sort of have a baseline, some type of level of confusion and probably anxiety going much of the time. So remember that emotions are contagious. People just sort of automatically mimic their companion's emotion, and they do it without even thinking. And so we all know this as professionals. We all have our private lives and our private concerns. But whatever baggage that we have, and all of us have it, we have to leave it at the door when we come to work. And we have to, maybe stop and take a couple of deep breaths. I always recommend this. I try to breathe deeply in through the nose and out through the mouth, exhale through the mouth, and try to center myself, and then put a big smile on my face, because I know that if I'm having a bad day, then my clients are going to be having a bad day as well. And as the slide indicates, a calm and relaxed caregiver equals hopefully a calm and relaxed client. So I want to cover these 4 communication strategies with all of you. And the first is, these are not just kind of strategies, they're really just sort of words to live by. The first is that you can't change difficult behaviors with words. Um, and, you could kind of reword this to say, you can't change the client. They can't change. But the good news is that we can change our approach to the client. We can definitely change our reaction if we're seeing some type of a behavior. And sometimes we can change the environment. So again, they can't change, but we can. We can change our approach, we can change our reaction, and sometimes we can make some tweaks to the environment. We need to keep in mind that once they have dementia, they have brain damage in the area. And remember the slides we saw last time with the picture of the brain and all the shrinkage and all the gaps that represented actual loss of brain cells. So we have to remember that that makes them incapable, of really learning new information. So they're dealing with additional damage as the disease progresses. So what does that mean? It means they really can't be told, um, you know, to do something with and be expected to remember that. And so this is just the way it is. Um, and I always say, if we lower our expectations, we'll lower our frustrations. Lower their frustrations, lower our frustrations, and things will go more smoothly. The second sort of strategy or words to live by is don't say no and never argue. So it's kind of human nature to try and reason with people. They may say something, well, they will say something that's not true. And again, you as professionals have sort of been dealing with these types of issues anyway, but I just want to heighten, some of this knowledge for you. You can't reason with a person who's just lost the ability to, process thoughts once they have dementia. So arguing is only going to elevate their frustration and their confusion, and they're going to get angry. And so the goal is not to be correct, it's to be kind. I mean, that should be everybody's goal in life, because I think we really sort of are from a society that just always wants to be correct. And it's better to be kind than to be correct. So, in the example you see here, and it's a very common thing, people often have delusions about, all manner of things, but in this example, your client is telling you that she's a movie star. Great. That's a pleasant delusion. Agree with her, because it isn't hurting anyone to let her live in that reality. I mean, all of us at one time have probably had dreams when we were kids about being famous, and, our actual lives haven't kind of lived up to that reality, right? So let her live in that world, and ask her to tell you more about that. Oh, that's so great. Can I have ask her for her autograph? It's always best to roll with the punches. Um, Go along with the fantasy. And dementia, one of the symptoms can be hallucinations or delusions. Hallucinations are seeing things that aren't there. Delusions are believing things that aren't true. And as long as they're not upsetting to the person, they shouldn't be upsetting to us. And we should just sort of ride it out with the person. So again, we remember that the person is experiencing a decline in their ability to reason. So that ability is declining. And at the same time, there's an increase in their emotional reactions. So, feelings are more important than facts. So we're not going to say no, and we're never going to argue. And we'll talk a little bit about, how we can redirect in just a few minutes. So, yeah, it's their reality, and it's our job to enter into their reality instead of trying to pull them into ours. So, we're going to validate, these things that they're saying. It builds empathy, it establishes trust, it makes them feel secure, and it reduces their feelings of anxiety. We enter their reality, we match their emotions. In this example, Tom is saying, hey, my mom was here today, and you know full well that mother is dead. And so your answer is not going to be, oh, I thought your mom died. It's going to be, how wonderful. You must love your mother very much. So you're validating Tom, and the outcome is great. It could be, the opposite would happen if you had told the truth, right? So in dementia care, we call this therapeutic fibbing. And not because we like to be liars, but because we like to see a positive outcome for our clients. The fourth strategy, or words to live by: reduce fear by acknowledging the underlying emotions. Again, it's all about emotions, because the emotions are accelerating while the skills are declining. So, and they're losing the ability to cope and express their fears. So, and again, we're going to talk about how they express these fears are in the form of behavioral expressions. So, people are losing the ability to self-soothe because they're getting overwhelmed. So the answer to that is reassuring the person, validating them, and responding to their emotions. We're going to just pay more attention to the emotions and less attention to the words, as they lose the ability to use words appropriately. Okay, so everybody just kind of take a look at this graphic. It's just a chart that gives you some ideas, and we've really kind of talked through most all of these. In fact, I'll eyeball it and see if there's anything we didn't talk about. It goes over the body language that we've discussed, um, eye contact, open stance, friendly, relaxed. It does mention use of humor, which goes a long way in making both your clients and yourself uh, happier. Smiles and laughter are wonderful. It's great medicine. I want to mention the use again of nonverbal language like prompts and cues. As people forget what words mean, you're going to use pointing and gestures. You can also use pictures, uh, picture of the toilet on the bathroom door, etc. As they lose language. All of these things are important. Let's move on to talking about challenging behavior expressions in individuals living um, with IDD. And here we're going to just talk about some of the common behaviors that tend to go along with Alzheimer's, some general tips, some typical triggers, and then, as I said, redirection and distraction. And so take a look. Here's a lot of what we see: pacing, repetition, which maps to short-term memory loss. So, the area of the brain that is initially damaged in Alzheimer's disease is the hippocampus, and that's the area that is responsible for taking in new information and saving it so that you can then retrieve it. And so that's basically broken. So you tell someone you have a doctor appointment today at 3, and it just goes in one ear and out the other. So then they ask you, where are we going today? And you tell them you have a doctor appointment at 3. And then 5 minutes later, it's what time is my doctor appointment, or where am I going? And it's endless over and over again, repetition. And so this one seems like it's not that big of a deal, but it's kind of crazy making. So just remember that this and everything else that you see on the list is not their fault, because it's beyond their control, and it's due to the progressing damage caused in the brain due to Alzheimer's. Rummaging, hoarding, verbal outbursts, all of the agitation, restlessness, paranoia, hallucinations that I've already mentioned, changes in their sleep patterns, sundowning, which is the best way to describe that is a change in behavior, acceleration of agitation and restlessness in the later part of the day. I mean, it really can start anywhere from 2 to 5, and just, this feeling of wanting to go somewhere, or a lot of pacing, or just it's associated with the sun going down. Resistance, where we didn't see this before, and changes in personality. And let me just say this about, when it comes to Down syndrome, when we're working with families, these personality changes are so painful. And when I say families, that means you guys too, because some of you, I know, have worked with your clients for a very, very long time. And so you're like family. They're, in many ways. And so it's painful, very hurtful to see people change from being very loving and motivated and affectionate and just easy to get along with and eager to please. It's hard to see these symptoms in your clients. And again, it's because of Alzheimer's. And so when you see these things, you can't blame it on the client, you blame it on the disease. And so I just wanted to mention that, because it's such a far cry. When it steals away their personality, and so we have to constantly remind ourselves that these symptoms are beyond the control of your dear clients. So behaviors can range from, just sort of frustrating to those that have the potential for serious harm. And we talked about this. I was doing this class yesterday, and a couple of the attendees talked about behaviors that they saw that were like hitting and dangerous behaviors. And so I'll just pause for a moment and say that when you see truly aggressive behaviors and people striking out, those that are a danger to themselves or to others, that requires elevation to, your supervisor, called a 911. Those are psychiatric issues that are emergent. They're emergency situations. But a lot of these behaviors, you have to kind of ask yourself, who is this a problem for? Is it a problem for the client, or is it a problem for me? And the example I gave a few minutes ago were delusions and hallucinations. Many times they're not bothersome at all to the client. And so they shouldn't be bothersome to us, and we can ignore them or just help the client through them. And another example is a lot of our clients, wear mismatched clothes, or they layer their clothes, etc. So I've had clients who, I had a client who whistled all day long, and it drove everybody crazy. So that was a problem for us. We have to accommodate that. It wasn't a problem for the client. So you sort of parse it out. And again, you ask, is this behavior have a potential for harm, in which case there needs to be an intervention, or is this something that we ignore or just, sort of accommodate? So we have to use our assessment skills. So the reality is that caring for someone with dementia requires a paradigm shift. So we have to really go through sort of a radical shift in our thinking. And so it's rehabilitation versus habilitation. And these are just kind of fancy terms. And I'll just break it down to plain language. When we're working with clients that don't have dementia, we're very goal driven. And each of our clients sort of has their goals, and we're always helping them to strive to do better and to improve. And so once they have dementia, our focus is no longer going in that direction. We're going to go in a different direction that's more like maintenance, more like we're going to help them to be as stable as they can. We want to keep them at their functioning level, their present functioning level, for as long as possible, knowing that they are going to progress, and that our goal is going to be to maintain their safety and their comfort and their quality of life. We're no longer going to push them to improve. We're just going to keep them functioning as best they can for as long as we can. We're going to maintain their safety and their comfort. Okay. So that's going to be our goal. So I'll just pause for a minute because this is really an important concept. Yep. It's all about maintaining their functioning level as long as we can, keeping everybody safe and comfortable. We just talked about all of this. Make sure they're attending before you communicate with them. Don't reason, don't argue. Do use fewer words than you did in the past. Stay calm, allow time. If you speak too loudly, they're going to think you're angry with them. Respond to emotions. We're going to use redirecting and distracting. If things aren't going well, step away and try again in a few minutes. And I'm re-emphasizing these communication tips at this time because the good communication is really the framework for you know, working with these clients. And when we use these tips, we're going to avoid a lot of the common behaviors that we see in this illness. So, really, the tools that we're using are going to prevent, sometimes at least reduce a lot of the problem behaviors. And that's the good news. And then, I mentioned assessment a few minutes ago. So when we do see behaviors, we have to sort of run through these questions in our mind. What is the exact behavior that they're doing? Is there a particular time of day that it usually happens? Who's around when it happens? There's certain people that are present. What happened before, what happened after, what things have we tried in the past, and importantly, because this speaks to a person-centered approach, what do we know about this person's life history? Many centers use the ABC model. That's antecedent, what triggered this episode? B for behavior, what is the actual behavior that's occurring? And then C, consequences, what happens afterwards? We know, for example, here, uh, like we might have a person who's becoming agitated at a social event or during an activity. So the consequence might be we're tempted to just say, well, we're not going to let them participate in that social event. Instead, maybe we could be thinking of a way that they could continue to enjoy that event, but in a way that doesn't cause them distress and disrupt the event. In all things, who has to change? We do, because as we've said several times today, we know they can't change. So we need to change because the behaviors that we're seeing are not the person's fault. They're due to this brain disease. And if we try to change or control the behavior, we're probably going to meet with resistance. So again, unless this is a violent behavior or aggressive behavior, we're going to accommodate it. We're going to accommodate it and not control it. For example, and this, I've had this happen in my support group. Family members have told me that their loved one wants to sleep on the floor. They don't want to sleep in the bed. And I've said, it's okay, just make them comfortable on the floor. So rather than constantly trying to put that person back to bed, accommodate the behavior, put a mattress on the floor or let them sleep, make a pallet of blankets and give them a pillow. And this is a great example of how we can change, or as I said before, we change the environment to accommodate the behavior. Recognize that there's usually a trigger. Behaviors don't just happen out of the clear blue sky. It's usually an emotional trigger or it's something in the environment. The task is too complicated or unfamiliar, or first and foremost, that person may be in pain, they may be sick, there may be a medical issue, and they're just not able to tell you about it. So, especially if the behavior has an acute onset, we always want to screen to make sure that there's not some kind of medical issue. So, that pain or discomfort could be caused by anything from a pebble in their shoe to a urinary tract infection. So, do rule out medical first and foremost. But then, look around. Like I mentioned, sundowning. Um, I don't know if there are any group home personnel on this call today, but toward the late part of the afternoon, you may want to close the drapes to avoid triggering sundowning behaviors, because as the sun starts to set, sometimes it creates shadows. Your residents may look out and see shadows and think they see people in the bushes. I mean, that's something that we've observed before. So a way to avoid that might be just closing the blinds and turning nice lighting on inside the home to avoid that. So yeah, we can change. The change the environment. Exactly. Um, the task being too complicated, we'll talk in the next session about activities, but sometimes activities that they've always enjoyed, they may not be able to do anymore, or they may be having trouble with. So we'll talk next time about how to downsize those activities so that they can still enjoy them, but a simplified version. Tasks can include their activities of daily living, things that they've always done may have too many steps. So we may need to provide more and more, we will need to provide more and more assistance with those things. So, you already do this in your day-to-day work, but I just want to heighten this as a key concept in dementia care, and that's redirecting. So we want to distract and divert. And we do this to minimize or avoid, verbal outbursts and, that whole range of challenging behaviors. And we redirect through gentle and skillful distraction. And we do that with activities. We suggest a desired activity, and that can include anything from providing, a favorite snack or something to drink or some conversation. We're going to use that great body language that we've been talking about. We're going to smile. We're going to use a reassuring tone, and we're going to use a lot of validation. So when someone is at their day program and they say that they have to go home to see their mother, and you know that their mother has died, then you're not going to argue with them. You're going to say, "Oh, your mother, tell me about your mother." Or you're going to say, "Oh, yes, your mother is such a lovely person. But before you go, why don't we make a sandwich, or let's play cards?" So it's reassuring, it's validating, but now you're introducing another subject and another activity. And the thought behind that is that the attention span is becoming shorter and shorter with dementia in the picture. And so hopefully he will forget mother and now be focused on making a sandwich. So that's, and you can think of your own examples. And here's one on our screen. So Joe is very agitated. I need to get to work. I'm going to miss my bus. And Mary is saying, "Okay, Joe, but I just made breakfast. How about we eat first and then I'll drive you to the bus stop?" So very simple, but effective. So let's practice. Who would like to respond to Helen? Helen is saying, "I want to go home. My mom is waiting for me." How would you respond? Who wants to take a stab at this one?
I would say, okay, you want to go home, let's get your shoes on and kind of distract in that way, like and then after we put our shoes on, maybe, okay, let's go for a walk, right? Something like that, just so that
Great.
I'm not arguing that we're not going to do that. I'm just kind of stalling until she forgets about it.
Yeah, and remember what we said earlier, never say no. Okay, you said okay, so you were validating. And then you did a very nice redirection. Very nice. Here's some more tips. Remember again, and we mentioned this earlier, that it can't be stressed enough. People with dementia are really good at reading your body language, so keep smiling, try to relax, and be warm and open when redirecting someone with AD. And you can ask questions, and you can say things like, "Tell me about it." So when they say, "I want to go home," you can say, "Tell me about your house. Do you live in a big house?" And then maybe just say something like, "I'm hungry. Would you help me get a snack?" And let me just add that when you ask someone with dementia to help you, that's really great, because a lot of times people are feeling like they're not very productive anymore. And so asking someone to help you, especially someone with Down syndrome, is always a winner because they love to help and to feel needed. So that's a good one. Be flexible, because you come up with all these great scenarios, and they're working, and then suddenly they're not working anymore. So the key to managing these behaviors is to be creative and flexible, and chat with your colleagues and come up with different ideas, and be patient with them and be patient with yourself. So yeah. So next time we are going to be talking about adopting a positive approach to caring for individuals with IDD and AD. Goodbye, everyone.